What I've done here is just put together some common things that men may go through at various stages of life, and please feel free to, this is a small enough group, you can just ask questions, don't even raise your hand, just blurt out when you have a question. Be happy to answer it. So just as a disclosure, I am a faculty member at UCF, and I also am a faculty speaker for multiple different corporations as part of the research and everything else. So, aging in men. So aging sucks, and I'm sure all of you know that on some level. But aging isn't the same for every sort of decade throughout life. Most of aging that occurs in men actually happens in late 40s, early 50s. It's not a steady sort of stream that happens from your 20s on. At around the age of late 40s, early 50s, it's a gradual sort of decline that I'm sure a lot of you have kind of noticed. It's not the same in females. In females, there's kind of a precipitous drop within late 40s, early 50s. In men, it is a much more sort of gradual slope. In some ways, that makes it a little bit more ominous because it's difficult to tell some of the signs of these things. And some of the things that can happen are changes in the incidence of diabetes, hypertension, hormones, blood lipids, prostate size, and fat distribution. So when we start talking about changes, it's really dramatic how all of these changes seem to happen at late 40s, early 50s, really minimally before then. But for example, prostate size, there are 2 times in a man's life where the prostate grows. One is during puberty, where it grows from the size of a peanut to the size of a walnut. Then it stays about that same size up until about late 40s, early 50s, where it starts growing again. Same thing with testosterone levels. So testosterone levels up through most of life stay, pretty okay up until about late 40s, where it starts to decline. The reason why it stays relatively stable is because this stuff called SHBG, or sex hormone binding globulin, starts going up. That stuff in your body, your blood, that actually bind testosterone and don't let it go. So even though your total testosterone stays about level, your free testosterone actually starts dropping precipitously. This is actually the evidence for hypertension, same sort of thing. Late 40s, early 50s is when it starts going up. In terms of obesity, it is less of an incidence versus the other things in this country, just because there seems to be an overall steady increase. But when we start to account for multiple different factors, it does start going up somewhat precipitously again, late 40s, early 50s. And finally, prostate cancer. So prostate cancer, we'll talk a little bit more about this shortly, but basically prostate cancer is the same sort of thing. The incidence starts to go up dramatically late 40s, early 50s. Now, as we'll talk about, that doesn't necessarily mean that that's all men that have to worry about prostate cancer, but the incidence starts going up late 40s, early 50s. So speaking a little bit more about prostate cancer, because that's the biggest worry for a lot of men, there are a couple of things to kind of remember about prostate cancer. The first is that, yes, it is ubiquitous. It remains the most commonly diagnosed malignancy among men in the United States, aside from skin cancer. However, having said that, it is not the leading cause of cancer death. Even though it is the most common cancer that's diagnosed, lung cancer actually kills far more men than prostate cancer. In fact, prostate cancer only accounts for about 3% of all male deaths in the US, which isn't a very high sort of number when you think about it. However, on the other end of the spectrum, at the age of 70, about 60% of guys will have at least a microscopic focus of prostate cancer. At the age of 90, 100% of guys will have it. So what does that mean ultimately? What it probably means is that there's prostate cancer and there's prostate cancer. There's kind of the low-grade, low-stage stuff that everybody gets. It's common. It's the most common it's the most common cancer to be diagnosed with men. But because such a few percentage of people actually die from it, it's actually very different than the prostate cancer that you hear about that really is a killer. So the important thing to remember about prostate cancer is even if you have a diagnosis of prostate cancer, it doesn't necessarily mean that that's something that would even necessitate treatment. Or even if it is treated, it doesn't have to be aggressive in terms of when or how you do it. which is very different than, say, for example, something like lung cancer. A lot of lung cancers, you do have to be very aggressive because it can cause, because its ability to kill the person is very high. But in prostate, for most prostate cancers, not all, but for most prostate cancers, it's a very slow-growing sort of disease. In fact, at the age of 75, after that, we don't even screen for it because, again, at that point, if you get prostate cancer, chances are you're not going to die from it. You'll probably outlive it. So when we talk about prostate health, of course, we worry about prostate cancer, but we don't, that's not exclusively what we're talking about. One of the things, the more common thing that we worry about is actually BPH, a large prostate. So this is kind of a schematic of what the prostate is. You can kind of imagine the prostate is like an apple that the bladder sits on top of. And the middle of that apple is what you pee through. And basically, if this is the, if the apple were smaller, you see that the core itself is wide open and you pee right through it. Now take this prostate on the right side of the screen, on your left. You can see that the actual, this isn't cancer, this is just a large prostate, has actually started to grow into the central tube that you would pee through. And as such, even though this isn't a tumor, it can cause a lot of issues. And what issues can it cause? Well, basically, the incidence of BPH is, well, usually like everything else I showed, it happens after the age of 40 years. By about 60 years of age, half of guys have it, more than half of guys have it. By the age of 85, again, 90% of guys have it. So just like prostate cancer, the prostate itself, when it grows in most men. However, this is not cancer. What it is, I know this is kind of a fancy sort of thing, but basically what this is saying is that the actual process that happens isn't a cancerous one. It's just a part of the prostate that grows bigger. It's not the same as prostate cancer. So how do you know if you have BPH? Well, basically you get up more than once at night without taking a diuretic. You may have some hesitancy and intermittency. What that means is that hesitancy is when you go a little bit, then you wait, and then more comes out. Intermittency is when you go and then you go sit for a while, and then you say, oh God, I gotta go again, and then you have to go back to the bathroom. You can also get some urgency and frequency sometimes where you feel like you have to go somewhat immediately, and sometimes you're going fairly often. If it's very severe, you could actually get what's known as overflow incontinence, where you're just kind of leaking all the time, and that's because the bladder's gotten so full that it started to actually leak out the front. So this is ultimately the problem with BPH, with a large prostate. Ultimately, what can happen is that the prostate can obstruct the flow of urine so much that you can get what's known as a trabeculated hypertrophic bladder, which means that the normal bladder wall is, going back to this, the normal bladder wall serves as a muscle that actually contracts to get the urine out. The problem is if it becomes really big, it can actually limit the amount of urine that's actually inside of it because it just has nowhere to go. And because of that, that can lead to a lot of frequency and urgency because you just don't have enough time to fill the bladder. The other thing that can happen is that if it's decompensated, meaning the bladder isn't able to grow in time to actually account for that obstruction, it can actually thin out. And if the muscle thins out enough, as you can imagine, it just won't contract to get the urine out. And then these things are like pipes, and like any other pipe, if it's blocked down here, it'll go all the way up, it'll lead to hydroureter and can lead to what's known as hydronephrosis. What that means is just a backup of urine that goes all the way to the kidney. That can lead to problems with kidney function and even can lead to kidney failure. Basically, if there is too much of a blockage of urine, the bladder itself can fill up, like we mentioned, and if it doesn't have anywhere else to go, then that can be a very painful sort of thing. You can actually need a catheter to have to drain that. And sometimes what can happen is that urine that sticks around in the bladder can actually sediment out, just like sugar and water. Mix a bunch of sugar and water, let it sit for a while, it'll all fall to the bottom. Well, same sort of thing in the bladder. If urine stagnates, then that urine can actually lead to problems where You can even get these things, bladder stones, literally stones that you form in the bladder because this urine just has nowhere else to go, and that precipitation event leads to a stone that gets bigger and bigger and bigger. So how do we treat large prostate? Well, basically there are a couple of different things. We can start patients on alpha blockers, which are basically things that open the area between the bladder and the prostate. So essentially what that does is that just kind of opens up the funnel here so that you have a bigger funnel to pee through. The issue with that is that it may cause what's known as retrograde ejaculation. What that means is that when you ejaculate, because that internal sphincter is open, it actually can go up into the bladder instead of out the way it normally should. There's no harm in that, but I mean, the only real issue is for people that still desire fertility. The other option is now you can actually use daily Cialis not for erectile function, for urinary issues. What it does is it actually relaxes the prostate capsule, so that allows for more of a urinary stream. And there's hormonal therapy, the 5-alpha reductase inhibitors. So those are things like finasteride and Avodart. What those things do is they actually stop one of the major fuels for prostate growth. What that does is the major fuel for prostate growth is this stuff called DHT, or dihydrotestosterone. That's like, that's like sugar for the prostate. It really grows very, very fast in response to that. Well, one of the things that these medications do is it blocks the conversion of testosterone to DHT. So that essentially kind of starves the prostate of one of its major fuel factors, and that's what allows for the prostate to shrink. Now, there can be some issues with that. It can cause a decrease in libido. It doesn't necessarily, it rarely does, but it can. And these medications were actually studied to see whether or not they can prevent prostate cancer. And it turns out they can. In about 20 to 25% of people that were studied, it prevented low-grade prostate cancer. Now, as you all know from what we had discussed, the low-grade prostate cancer may not be so much of a problem. The problem with those studies is that it increased the risk of high-grade prostate cancer. Now, it increased it very minimally, 0.5 to 1%, and it was unclear whether or not that represented a true increase, because it could be just because you shrunk the prostate so the cancers look worse on the ones that had cancer, or it could be because you shrunk the prostate, you had a higher chance of getting a positive result. But regardless, those studies did show a small increase in prostate cancer. So what if you don't want or you fail the medical treatments? Well, there's surgery, but now we live in a time where there are alternatives to even surgery. There's actually in-office procedures that we can do. So one is microwave therapy of the prostate, where essentially we put a catheter that has these microwave coils in the middle of it, and these microwave coils actually deliver thermal energy to the prostate to kind of open up a tube so that you're able to pee better. The other thing that's now available, and when I say now, I mean literally it's been out for a month, maybe, month and a half, is UroLift. So that usually is done with minimal sedation, though it doesn't have to be. And basically what it is essentially kind of using kind of like tacks to tack, if this is the prostate and it's blocking the flow of urine, these tacks actually kind of open up the channel so that you're able to pee more. That's not a surgical procedure. It's not anything. It's literal. You can do it even with a blood thinner. Basically, all you're doing is just kind of opening the lumen so that you can urinate better. Then there's the gold standard, which is the TURP, the transurethral resection of the prostate, where we take kind of an electrocautery type machine and just kind of scrape out the part of the prostate that's blocking the flow of urine. There's also the laser procedures, which are newer and cause less bleeding than the TURP, where we use a laser, and we use different forms of the laser to actually vaporize the prostate. Sometimes we cut out chunks of the prostate while we're vaporizing. And then there's the old-fashioned way, which has been done for 60 years at least, and that is to enucleate the prostate, to actually literally rip out the part of the prostate that's causing the problem. Now, this is kind of one of the ways we do that, and essentially what you're doing is there's a capsule that I've kind of shown on a lot of these pictures that surrounds the prostate. What you do is you actually keep that capsule intact so you don't have issues with erectile function, and incontinence. And what you do is you actually kind of finger fracture and use scissors to actually cut out this chunk of the prostate. It's like opening an orange and scooping out the meat of the orange while leaving the peel of the orange intact. So we only really reserve that for patients that have a very, very large prostate that we can't do any one of these other procedures for. So in summary, there is a lot to the prostate. There is an increased likelihood of getting prostate cancer with age. Having said that, most of the time that prostate cancer is going to be inconsequential. Not always, but most of the time. There is an increased likelihood of low testosterone with age, and we'll talk about that a little bit. And there's an increased incidence of all these other issues, lipid abnormalities, vasculopathy, but also with BPH issues with age. So one of the things that we talk about when we talk about, so here's the prostate right here. But one of the things that we talk about is the prostate when we talk about anything with the prostate as it relates to erectile function. And this is the reason why. Basically, this is, you can guess what this is, but basically this is the prostate, and these are kind of the nerves and the blood vessels that go to the penis as it relates to the prostate. I know this is kind of a busy slide, but basically what's going on here is that the prostate has a lot of, the prostate after all is a gland, and that gland has a lot of veins that kind of surround it. And those veins actually lead directly to the penile veins. And the nerves that are responsible for innervating the penis run right alongside the prostate. So that's why it's so important to keep that shell whenever you do that kind of surgery, whatever kind of surgery to the prostate. You want to make sure that these nerves stay intact so that they can actually innervate the penis and that doesn't lead to any kind of erectile issues. So the way an erection works is that you have these actual sinusoidal spaces in the penis that actually respond to that nerve impulse. So that nerve impulse comes through that allows for these sinusoidal spaces that are normally like this to look like this. That same nerve impulse allows these arteries that come in to go from here to look like this. So basically what happens is that you have that spongy part of the penis, you have the artery that feeds blood in and the vein that takes blood away. You give that nerve impulse, and then you allow for those actual cavernosa to increase in size, and now everything kind of expands. The blood vessel gets bigger, this cavernosa expands, and that actually pinches off the vein. So you have blood that comes in, can't come out. It's essentially a one-way valve, and that's kind of how an erection works. So when we look at problems with erectile function, we look at each one of those things to see what the problem may be. So that's why we start talking about a lot of these other things that I mentioned earlier. Hyperlipidemia, basically anything that clogs this artery over here can lead to problems with the flow going in, and that could lead to problems with erectile function. So hyperlipidemia are things like cholesterol and such that can actually prevent flow within it. So oftentimes diet and exercise, although those are important to help to restore that stuff or to maintain it, oftentimes that's not enough. You also have to address some of these other things as well. Testosterone is one. Testosterone is kind of the male hormone. It gives us our body structure, it gives us our facial hair, and as far as this whole process goes, it actually is responsible for this part right here. It actually is responsible for these actual sinusoids to actually get bigger. So that's why a lot of times if the testosterone is low, if the Viagra, Levitra, Cialis, those medications are on board, they may not work. If the testosterone is low enough, then if this process doesn't occur, then obviously you won't get an erection. This is also the reason why men get morning erections. Usually men are on a circadian rhythm where their testosterone will go up at 4 a.m., peak at around 8 o'clock, and go down during the rest of the day. That surge initially in the mornings is what allows for that cavernosa to open and to have erections in the middle of the night and in the morning. Diabetes and hypertension, those are also important because, again, anything that feeds that blood flow that comes into the penis can affect erectile function. The corpus cavernosa, like we talked about, this is the sinusoids that we talked about. These are what are directly affected by testosterone. They're also affected by these medications. So basically the way these medications work is they don't actually open these, but they keep them open for longer. So again, that's the reason why the testosterone needs to be up at a certain level for these medications to actually work. And they can be negatively affected by medications. The actual medications can not only affect the way the blood vessels open up, but can also affect the way that these actual cavernosa open up. And the venous drainage. So essentially, one of the things we do is if we don't find an issue with one of the first two things, then we check to see whether or not there's an abnormal venous drainage. Basically, we check to see if blood flow is going in and then just coming out just as quickly. So how do you tell? How do you tell if it's any one of these things? Well, basically, you check each one of these things. So you check a lipid panel for arterial flow. You check diabetes, hypertension, and make sure they're controlled for the arterial inflow. You check testosterone, not only for the arterial inflow, but the cavernosal function. You check to see if there's any kind of drug effect for any one of these things. And if all these things are negative, then you check for a venous leak. Also, if there's a history of trauma or a younger patient, then you want to check to make sure this isn't going on. So how to treat? Well, basically fix whatever's wrong. So for a lipid panel abnormality, basically you can do things like statins. You can also do things like diet, exercise. Also diabetes and hypertension, treating those things can help. Testosterone can help not only with the lipid panel, but can also help as far as cardiovascular function in general, and also the function of these things. And because they actually allow for those things to open up, they can actually help the efficacy of all these PDE5 inhibitors, the Viagra, Levitra, Cialis, those kind of medications. So testosterone, of course, is important. It plays a role in energy, libido, erectile function. It can help cognition, memory, mood. It can also help things like osteoporosis and cardiovascular function. It affects many different organs in the body, and because of that, there are effects in many different organs in the body. This is also the reason why, if you're on testosterone replacement, it's really important that you follow with somebody that really knows how to follow each one of these things so that you don't run into problems, say, for example, with an increased amount of kidney stimulation leading to an increased amount of erythropoiesis, meaning increased blood mass. That increased blood mass can cause things like coagulation. So you need to make sure you're following with somebody that has an appreciation for these things and knows what to look for. So the PDE5 inhibitors, there's Viagra, Cialis, Levitra. Now there's a new one. The Staxin is just like the Levitra. Now there's a new one called Stendra. They all work slightly differently. So if I were to draw Stendra on the graph, it would be right here. It'd be even closer than the Staxin. But basically, the Cialis works for the longest period of time, but works on the least amount of people, versus something like the Stendra, which is even more than these. It would be a peak like this, where it works for a very short amount of time, but works very rapidly and probably on the most amount of people. So PDE5 inhibitors can be potentiated by testosterone replacement. By themselves, they're only effective in about 50% of cases. So if those medications don't work, what do you do? Well, basically, there is a vacuum erection device where basically it's kind of a cylinder that brings blood into the penis, and there's like a little ring that goes on the base of the penis to keep the erection up. There's also intraurethral injections, which are basically injections that actually go into the penis itself to cause an erection. However, and there's also intracavernosal injections. And the reason why intracavernosal injections work, intracavernosal injections are actually injections directly into the spongy part of the penis. So basically what we do is, if there's a problem with either the nerve impulse coming through or the blood vessels, the blood vessel itself isn't dilating enough in response to stimulus, what we do is we actually inject a substance directly into the cavernosa, and we teach you how to do that. And what happens is that then artificially allows for these cavernosa to open, and that leads to the whole erectile cascade. So basically what it is they draw it here like it's a painful sort of thing, and it can be a little bit painful, but it's not as much as you would think. It's more a psychological sort of thing. And most of the time the pain's only the first couple of times. After that it doesn't hurt, but it is a psychological barrier sometimes. And basically what it is it's injection directly into the spongy part of the penis to allow for an erection. If that fails, or if it's expensive, or if, for whatever other reason, there is the penile prosthesis, which is either a same day or overnight surgery. Basically the biggest risk of it is infection. So we give multiple antibiotics to prevent it. It's actually very effective, 95% patient satisfaction rate and 90% partner satisfaction rate. However, it is a permanent procedure. There's no going back on it. And there's a bunch of different types of prosthesis. This is a 3-piece prosthesis. This is a 2-piece. This is an ambicor prosthesis, which is a kind of a 2-piece with a pump on it. And essentially what it is this is semi-rigid prosthesis. We actually put it in the machinery of the penis to actually allow for an erection. The semi-rigid is just, you just point it whatever direction you want to point it to. The ambicor shown here is you have the pump that actually fills these cylinders. The 3-piece allows for these to become, to go through a central pump and then back into a cylinder. So you can actually pump this prosthesis to actually pump these things to get an erection. So the reason why erectile function and testosterone are important, again, aside from an erection itself, is endothelial function and libido. So sometimes, even though you do all these things, it may not actually help overall with sexual function because you may not be in the mood or you may not have the desire or that kind of thing. And that's where testosterone can also help, whereas it may not help with, whereas one of these other measures may not help in and of themselves. So I get the question all the time about testosterone and its effects on prostate cancer and cardiovascular health. So basically, what we know about testosterone is that it does improve all these things. It does decrease cardiovascular risk. There's been some studies recently that have shown an increased risk of cardiovascular disease, but we believe those studies to be, well, kind of in a specific population of people and probably false. So if you're over the age of 65 and you're starting testosterone replacement, you just have to be sure you're following someone that is capable and knows what to look for any kind of risks with it. As far as overall prostate cancer and testosterone, basically there is some evidence that the prostate actually contributes to testosterone. So sometimes when somebody's had a surgery to take out the prostate for prostate cancer and they have issues with erectile function, a lot of times that has to do with those nerves that I showed you being damaged. But sometimes it also has to do with testosterone itself that may be playing a role locally that the prostate produces that may help with erectile function. As far as testosterone causing prostate cancer, the issue there is that for years we used to think, well, the reason we used to think that there was an issue had to do back with the original studies looking at testosterone prostate cancer. Basically, Huggins and Hodges, these two guys in 1941, they showed that decreasing testosterone levels, they thought cured prostate cancer. Well, it doesn't cure it, it just slows the progression of the disease. So for years, physicians used to think, well, low testosterone, low prostate cancer, well, that must mean high testosterone, high prostate cancer. Well, in the 1990s, basically people started to think that, well, that you can take advantage of this by giving testosterone before radiation and or treatment for prostate cancer, and that way you're kind of causing more cells to divide so you get all of it with whatever treatment. But it didn't turn out to be the case. It actually didn't affect outcomes one way or the other. So people thought, well, that's kind of odd. If this is true, why doesn't this work? And in the 2000s, they started giving testosterone during or after prostate cancer, and basically they showed that these patients did a lot better and their prostate cancer didn't change. And then we started being a little bit more aggressive in terms of treating people with active prostate cancer with testosterone. And what we found is that for the majority of cancers out there, it makes no difference. It doesn't change the way the cancer works. So the reason why that may be the case is because basically you have to understand something about how a prostate cell works. Basically, I call it the car garage hypothesis. And what that is that the actual prostate cell itself is kind of like a house with a 4-car garage. Well, it doesn't matter if you have 4 cars or 20 cars, only 4 cars are actually going to fit into that garage. Now, say for example that house now has changed so that now you have 7 receptors on it, or 6 receptors in this case. Well, now those two cars really make a difference because now it can accommodate more. In other words, if this prostate cell develops changes so that it can accommodate more testosterone, well then even little bits of testosterone make a difference in terms of it growing and dividing. And that's ultimately what we talk about when we talk about the difference between prostate cancer and prostate cancer. It's kind of the ability for that cancer to actually change its characteristics, to become more aggressive. Those are the ones that we need to treat. The ones that are kind of like this, that act kind of more like normal prostate cells, well, those really, we probably honestly have been over-treating for years. Probably don't need treatment. So is it safe? Yeah, so basically testosterone we give for people that have PSA less than 0.1. If you had some kind of treatment, we usually delay it a little bit to make sure the treatment's worked, and then we give testosterone. Sometimes it's hard to follow radiated patients because it's hard to tell how much. You need a little bit of time to figure out if the radiation worked, and sometimes it makes it a little more difficult to give testosterone in those patients. But overall, it looks like testosterone really does help with a lot of these things, and it's probably safe to give in a lot of people. So there is an overall improvement in quality of life, overall improvement in health quality in men's health, and it may be essential for the return of penile function, and the long-term safety probably is beneficial in patients with prostate cancer, probably more beneficial than not. So I know we kind of covered a lot of ground. I'm sure you guys have questions. I'm free to answer any one of them you may have about any one of these things.